Hello everyone, greetings from Dr. Prepper. I am currently working as a senior resident in CMC Vellore and therefore having worked in multiple departments have gained a lot of experience in medicine, surgery, orthopedics and critical care. So I have undertaken this project to help NEET-PG aspirants solve clinical questions because knowing how to approach these questions and getting the right answer, it is what is going to help you do well in these exams and fulfill your dreams. So let's dive right into it and hope you like the video.
So this question came actually in one of the NEETs of the past couple of years, where the question goes as, which part of the leg does one get claudication pain in femoral popliteal incompetence? And the options were thighs, buttocks, calf and foot. So the correct option to this question is C, which is calf. So how to approach this question and how we arrived at this answer is what we are now going to talk about. So let's look at the topic for today, which is peripheral artery occlusive disease, or PAOD, or PAD as some people call it.
So as the name suggests, peripheral artery occlusive disease, the explanation lies right in the name. Peripheral as in the lower or the upper limbs, very distal vessels that we know about. Artery as in the vessels that supply oxygen and nutrients to these parts of the body, to the muscles, to the tissues. Occlusive as in there is some kind of occlusion or blockage, and this blockage usually leads to what we call as limb ischemia, or a state where there is not enough arterial blood supply reaching the tissues. And disease as in it is a pathological process. So any occlusion or blockage in the peripheral vessels leading to limb ischemia is what leads to peripheral artery occlusive disease, and this leads to something called claudication pain. So claudication pain, it is a cramping type of pain that you get in your lower limbs after usually some exertional activity, which is most for our population mostly is walking. So you get this cramping type of pain when you walk a certain distance, and after that sometimes you need to seek rest, and only after that you are able to walk. So this severe pain in the lower limbs, or occasionally in the upper limbs also, you will get when you have PAD. So what are the risk factors of this disease? The most common risk factors are smoking, diabetes mellitus, or DM as people call it. It can be hypertension, or it can be trauma. In an acute setting, if it's very sudden onset, it could be trauma, which causes the vessels to go into spasm, causing these similar symptoms. Another concept I want to introduce to you guys is claudication distance. So what is claudication distance? Claudication distance is the distance an individual is able to walk after which he starts getting pain. So imagine if this is 0.0 and the patient is able to walk an X amount of distance, after which he reaches a point where he needs to take rest. The pain is so severe that he needs to rest, sit down, and once the pain subsides, only then he is able to continue walking. This distance X is called claudication distance. Now what is important to know is this distance X is a fixed distance when it comes to arterial claudication. Every day they will say, sir, I get up, I leave my house, I'm able to walk about 100 to 150 meters, and after that the pain is so severe that I have to sit down, I have to rest. So knowing this fixed distance or claudication distance is important because it is often used to assess progression of the disease. If a patient's claudication distance is progressively decreasing, means that disease is progressively worsening, and that helps to decide whether they need any active intervention right now or not. So now that we know what claudication exactly is, we have to come to the classification of claudication. So the most common classification used is this Boyd's classification of claudication. So it divides claudication into 3 grades. Grade 1 is when the patient develops pain on walking, but if he continues to walk, the pain disappears. So why this happens? This happens because of something which is called as substance P, which is an acute phase reactant. So when the muscles start cramping and tiring out because of the lack of oxygen, substance P accumulates and causes pain. But when the person continues walking, the substance P gets washed away and therefore the pain resolves. The next grade is grade 2, when the pain persists on walking, but they can continue walking with some effort. Grade 3 is actually the level at which patients present to you. So grade 3 is when, due to severe pain, the patient needs to rest. So as we had discussed about claudication distance, after walking a certain amount of distance, the patient develops such severe pain that the patient has to rest, and only after resting, when the pain resolves, is he able to walk again. So that distance at which the patient seeks rest is known as claudication distance, as I explained previously. So grade 3
is actually the level at which patients present most commonly. So you must remember, it's a very key part of history, and this is the grade at which patients usually present to OPD. So now that we have looked at what claudication is and we've classified it, we need to come to where the claudication pain occurs. So for that, we need to have an idea about the anatomy of the lower limb. So let's have a look at that. This right here on top is the aorta, which divides into the common iliacs, which divides into the small vessel is the internal iliac. This is the external iliac, which divides into the common femoral, which divides into the superficial femoral, which continues as the popliteal vessel. The popliteal vessel gives the anterior tibial and the tibio-peroneal trunk. So this bifurcation in tibio-peroneal trunk further gives the posterior tibial artery, as you can see, and the peroneal artery. So a question from here that often comes is, which of the following arteries trifurcates into its branches? So the trifurcation is for the answer to that question is the popliteal artery. Why it is called a trifurcation? Because a lot of people believe the popliteal artery straight away divides into its 3 terminal branches, which is anterior tibial, posterior tibial, and peroneal instead of a tibio-peroneal trunk. So that is an important thing to know. So now that you know the vessels of the lower limb, we can go on to describe the segments of disease that is often seen with PAOD. So coming to the location of pain. So for this we need to classify this peripheral arterial occlusive disease based on the levels or the segments of disease. So now that you know the anatomy of the lower limb vascular supply, let's talk about the segments of disease. So the first segment is the aorto-iliac segment, when the occlusion is between the aorta and the iliac vessels. None of the lower limb pulses are palpable in this disease. The next level is iliofemoral. In this also, none of the lower limb pulses will be palpable, but the block is somewhere between the iliac and the femoral vessels. The next level is the femoropopliteal vessels. So here the occlusion is between the femoral vessels but above the popliteal artery. So the femoral pulse will be palpable. However, the popliteal and other pulses will not be palpable. Then the lowest and the last segment is the infrapopliteal disease. So as the name suggests, below the popliteal level, all the occlusion is present. So femoral and popliteal pulses will be palpable, but dorsalis pedis and posterior tibial will not be palpable. So how does this correlate to where will you get pain? So if you have aorto-iliac disease, you will get pain in your buttocks. If you have iliofemoral disease, you will get pain in your thighs. If you have femoropopliteal disease, pain in the calf. And if you have infrapopliteal disease, you will get pain in the foot. So based on this, now it's very easy to see that the answer to our question that we discussed earlier was calf. Calf was the right answer. So now you may ask me, but what if there is occlusion at the iliofemoral level? Why don't we get pain in the calf or the foot? Why only thighs? So the body is built in a beautiful way in that the vascular supply has a lot of collateral vessels. So these collaterals ensure that there is some supply from some of the other arteries into the distal areas. So classically, I'm not saying the patient will exactly present to OPD like this, but classically, if you have a segment of disease like the iliofemoral, only the local area supplied by that segment is where the claudication will be most severe. So classically, the claudication will be most severe in the thigh. They might have pain elsewhere also, but it will be most severe in the thigh. So that is the reason why, in spite of having higher level disease, why you don't get pain in the lower places also. Let's look at some other topics they might ask from this particular area of interest. So how do you evaluate these patients who have PAOD? So the gold standard right now is to do an ankle brachial pressure index, also known as abbreviated as ABPI. Some people also call it an ABI, ankle brachial index. So this is the gold standard of checking this ABPI, which can also be asked is the Doppler method at the moment. This is the gold standard. So what is ABPI? So the formula goes, it is a ratio between the highest systolic beep pressure reading at the ankle. So you inflate a BP cuff around the calf, and at whatever pressure reading you get flow in the dorsalis pedis or the posterior tibial, the highest of the two values becomes your numerator, the highest systolic BP reading in either arm becomes your denominator, and you get this ratio. So in this ratio, the normal range of this ratio is 0.9 to 1.2. Some books even say 1.3. So this is normal. If it is less than 0.9, there is some form of limb ischemia. If it's less than 0.3, that is known as critical limb ischemia. Another question that might be asked, how much of an ABPI is critical limb ischemia, which requires some form of intervention. So you might also ask, what if the ABPI is high? Why can't it be more than 1.3? So there is a condition called arteriosclerosis. Please do not confuse this with atherosclerosis. Arteriosclerosis is when there is calcium deposition on your vessels. So they become hard, they become rigid. In that case, you might get an ABPI of more than 2. So this is a relatively rarer question, but this might also be asked about ABPI.
So some other questions that might be asked from this topic are, when we are treating this condition, what are the common grafts that are used to bypass these blockages which cause ischemia? So for the native graft or for the autograft from the same body, the most common vein used is the great saphenous vein. When you look at allografts or artificial grafts, they can also ask which material is commonly used to make these vascular grafts, and the answer to that is PTFE or polytetrafluoroethylene. So these are also two common questions that can be asked from this topic, and now you know the answers.
Last topic from this area of interest that I want to speak about is Berger's disease, which is also known as TAO. So what does TAO stand for? TAO stands for thromboangiitis obliterans. You can get this question as to what does TAO stand for, or what is Berger's disease also known as, and various permutation and combination of these words. But the correct answer is thromboangiitis obliterans. So it is usually a infrapopliteal disease which is seen where you get occlusion of the very distal vessels of the lower limb. The highest risk factor is smoking. So how you'll get this question is, they'll make a clinical scenario out of it where they will be like, particular patient came, an elderly gentleman with a very long pack year history of smoking, about 20 to 30 pack years, with gangrene or severe claudication pain in the foot as presented. What is the most likely diagnosis? So the answer to that will be Berger's disease or TAO or thromboangiitis obliterans. So that is another question that can be asked and therefore very important to know.
So that's it for today's question. Please like and share this video so that more and more people can benefit from this endeavor of ours. Please subscribe to the channel so that you can continue receiving more videos and more content like this. If you have any questions or topics you would like me to cover, please let me know in the comment section so that I can come up with any clinical concepts associated with it. See you next week. Keep up the good work and all the best for your NEET.